Madame and Monsieur, I regret I will be giving my presentation in English as well, but even worse, my parents raised me in Yorkshire, so my accent is even worse. I apologise. Here we'll go. So my name is Mike Norton. I'm from 3M Health Information Systems, and that's an awfully long title. But essentially, I hope to use the next 15-20 minutes to talk to you about value-based payment systems in the US specifically. It's always nice to start with a definition, and I stole this one from the New England Journal of Medicine. Value-based healthcare essentially model where the providers are paid based on patient health outcomes. So we're moving away from pay for service to a situation where we're paying for the results of care, the outcomes of care, not the process that go towards delivering that care. Okay? And essentially value in this situation is the measurement of outcomes against the cost of delivering those outcomes. Value is pretty much the same in all settings. Why do we need value-based healthcare? I stole this as well from the Institute of Medicine, but I think it's a very good slide, though some of the numbers, possibly to European eyes, may seem a little high. 1 in 4 patients report in the US that they have, physicians have had to reorder tests for them to continue their health care. 1 in 3 have been harmed by their stay in hospital, and 1 in 5 have been returned to hospital within 30 days. So we've got wastage, we've got harm, and we're not doing the job right in the first place. Interestingly, just from a UK perspective, the NHS is introducing the Get It Right First Time initiative this month just to address these sorts of issues. And we've also got wastage. 1/3 of the money that is spent in the US, it's estimated, on healthcare doesn't actually make people better. So that's important. And then we've got to think about scale. There are 5,700 registered hospitals in the US, translates to about 900,000 beds, something like that. Molly mentioned GDP earlier. Estimate is GDP, healthcare will account for 20.3% of GDP next year in the US. That's up from 16% in 2007. By comparison, the UK, we're just getting into double figures, where something like 10.002%. And I believe in Switzerland, you're just about 12% this year. So as Molly said, touching towards the end of the higher edge of the European range. And then we've got the wastage we talked about there. And unnecessary services at the bottom there are quite impressive. 210 billion in services. So we've got a lot of providers, a lot of money, and a lot of waste. Okay. And just show you this from the Commonwealth Fund. And you can see there the US as an outline. You've got basically health expenditure across the bottom axes and performance of the health system on the vertical. And you can see the US way out there, and if you haven't got a pointer, I apologise. But you can see Switzerland coming out there, just nudging above the average, and you've got the UK and Australia up at the top there. So we need to move from volume-based healthcare to value-based healthcare. There are perverse incentives on a volume-based healthcare system. Certainly, you've got payers or commissioners of health. They want to balance the books. So how do they balance their books? Try and pull back on some care. Try and keep some money back. You've got providers of care. They're hospitals. They're big organisations. Certainly in the UK, they are just the same in the US, I imagine. So they've got infrastructure. They've got wage bills. They need to balance their books, and the way they can balance their books is getting more throughput on a fee-for-service basis. So with value-based healthcare, again, we're going to focus on the wider results of healthcare and avoid the payment fee-for-service, I apologise. This is one of my favourite quotes. This is from Toby Cosgrove. He's an MD. He was a heart surgeon, and until recently he was President and CEO of the Cleveland Clinic. Value-based healthcare is inevitable, and that's good. That's a quote from him, and it's also the title of a paper he wrote for the Harvard Business Review back in 2013. And if anybody would like any homework, I can thoroughly recommend reading that. It's a very, very good paper. Okay. I don't normally set homework, so don't worry. Okay. So value-based healthcare in the US. All started in about 2010 with the Patient Protection and Affordable Care Act, also shortened to the ACA, also known as Obamacare. Lots of organisations have adopted value-based healthcare. We've got Medicare, Medicaid, and the commercial insurance plans. Things like, or organisations like Wellmark, Blue Cross Blue Shield, they all have value-based plans. Common elements to value in every setting are quality and cost. What quality are you receiving? How much are you paying for it? The challenges in healthcare, how do you measure quality? And I'll come on to that in a minute. CMS, probably the largest payer, has seven in fact at the moment. We've got some broad-ranging ones. We've got the Hospital Value-Based Purchasing Programme. We've got programs about physicians, their home health. We've got ones about skilled nursing facilities. And then we've got more focused, more narrow programs around readmission rates and hospital-acquired infections. So I'm just going to look at the first one for a minute. That's the Hospital Value-Based Purchasing Programme, introduced in 2013. It's got a number of clear aims. Reduce adverse events, improve the experience of the patient coming into the hospital, make it less traumatic, use evidence-based standards for improving care pathways and care in general, and higher quality at lower cost. So anybody, again, probably aware that ties in pretty closely into the IHA triple aim developed by Berwick, Nolan and Whittington back in, I think it was 2008 that came out. But theirs is improve the experience of care, improve the health of the population and improve the per capita cost. And that triple aim is a really important theme in this subject. How do they do it? Effectively by withholding Medicare payments to a given percentage. That is put in a pot, and the pot is paid out again based on the performance of the individual hospitals. And it's measured, your performance is measured on something called the total performance score. But just before we look at that, I thought it was interesting to look at some numbers. I'm a numbers kind of guy. So in financial year 2013, 1% was withheld. This year, we're looking at 2%. But the fun bit is looking over the far side. $1.7 billion. Okay, that's a pretty substantial sum. So how do we allocate it? Well, we allocate it based on domain weights that feed the total performance score. You've got essentially four key domains here. You've got domains around the patient experience. So that's things about pain management. Was I left in pain overnight? Communication. Did the nurses talk to me? Did I understand what was going to happen to me? When I asked for something, was it brought to me? Were the sandwiches nice or were they dried up and curled at the edges? All those sort of things. And they're generally recorded using surveys. Then we've got outcomes, 30-day mortality rates, around AMI, heart failure and pneumonia. There's items on the clinical process, and the one that I think is particularly interesting is the area on safety. The ones highlighted are ones that were introduced in 2017, so it's not a static system. It changes each year. Although I presume most hospitals actually did know what their CDI and MRSA rates were before they were encouraged to record them through CMS. So you've got the recording of infections. You've also got a compound score with the PSI 90. As you'd expect, that's a sort of compound score based on essentially elderly care, because this is, at the end of the day, a value-based payment system around elderly acute inpatient care. Okay, it's worth stating that. So the things you'd expect: pressure ulcer rate, hip fracture after fall, and then sepsis after the post-operative. Okay. I suppose the million-dollar question, before we look at some other examples: does it work? I'll quote an American colleague of mine. He said, "There's no slam dunk," which basically translates as there's no hard proof that it's worked. But what I can tell you, and there was an interesting paper by Pamela Spain, RTI last year, again, homework if you want it. But effectively, what they were saying there was, and if we go back, the areas of mortality over there not really changed over the life of the program, be it the program's only in its 4th year. But what has gone down are hospital-acquired infections. That's been significant and that's traceable. The other value for me personally is that if you introduce good quality into a system and around, let's say, acute elderly inpatient care, that good practice percolates into other areas. Other people benefit. Good practice spreads. And I think that's really important. I know it's hard to measure in some respects, but it is important. And the other, just to give a balanced view, the sort of negative element, if there is one, is that certainly there's feedback, again from the Spain report, that hospitals report the extra burden of collecting information. So, you know, one of the things about introducing value-based care is choose to measure what matters. Don't just go for a big, broad brush. Choose what matters to you, what you want to change. Okay, so I'll go forward. A couple of other examples, and these are quite well established. Maryland quality-based system, similar, very similar to the last one. We're looking at a scoring system, we're looking at a budget-neutral system, but we're only looking at 0.5% of budget at risk. Over 2 years, they were able to prove that they reduced hospital-acquired infections by 15.25%. The financial saving related to that, 111 million. And the fun bit, I know I probably shouldn't find that much fun in these things, but I need to get out more. If you extrapolate those numbers out, it's $1.3 billion for the whole of the US over 2 years. That's a pretty substantial sum. Value-based payment systems can also be quite niche. This is the Minnesota RARE project, reducing avoidable readmissions effectively. Slightly larger, 82 hospitals, 100 community partners, but they prevented over 6,000 avoidable hospital readmissions. They had almost 25,000 fewer inpatient days and saved 55 million. In fact, they won a patient safety award in 2014, the Eisenberg Award, for this program. Quite a lot of information about it on the internet, really quite interesting. But it's that focus. It was a problem, and they focused their efforts, and they configured the system to encourage providers to actually contribute and make change happen. Okay. So we want to go on the road to value-based healthcare. Yippee, great, fantastic. Where do we start? It all starts with data. It's as simple as that, I'm afraid. You've got to pull the data together. Without data, you don't know the is situation, the current situation. Without data, you can't identify those opportunities to change. Without data, you can't design new programs. And certainly without data, you won't be able to tell if those programs are working. Okay, you won't be able to track your progress. And here's the even fun bit. Acquisition and aggregation of data is tough. It's not easy. Bringing it all together is a big job. Please do not underestimate the effort involved. Fortunately, here's a little cheat sheet. Okay, I stole this from my US colleagues. So, secure your data. Understand where the data is. Pull it all together. It may be in claims, inpatient, outpatient. You're building a longitudinal record, just as Molly has with her group, of the patient, so you can understand their care needs. You were Europeans, be aware of GDPR. It's coming towards us very quickly. You've got to put it somewhere and you've got to validate it. Not just validate it for integrity, make sure that in the numbers columns there's numbers and in the data columns there's data. Validate it from a business point of view, from a clinical point of view. Make sure you haven't got discharge dates before admission dates. Make sure you're not giving hysterectomies to men. This sort of thing, okay? So what you're going to do once you've got your data, you're going to reduce variation. Appreciate all Molly's comments and the other comments you're going to hear today, but in the US, you can still pay a different price for the same procedure with a different physician in a different facility. You may even pay a different price with 2 different physicians in the same facility. And you've also got variation in outcomes. Okay, so that's important. And the other thing I'd mention about variation is think about risk adjustment. You've got to, and I'm quoting again from Molly here, you've got to compare apples with apples. Absolutely critical. Introduce value. As I said before, it's always the same. Value is quality divided by cost. It's the same everywhere. But as we mentioned earlier, think about the things you're measuring. We've just seen the HVBP. Lots of measures, lots and lots of measures. But then we've seen the RARE program, much more finite, much more focused. But you can measure things like, well, measure what's important to you effectively, but measure things like potentially preventable events, potentially preventable admissions, readmissions, attendances at A&E through poor continuity of care, hospital-acquired infections, variation in risk score. Is my population going up or is it going down? Measure what matters to you. Because the phrase certainly we use in the UK is, what gets measured gets done. It's a really simple phrase. So we've introduced value. We now need to understand our total cost of care. And this is really important. It's about all providers in all settings. So it's from effectively disease onset to cure or otherwise at the other end. So it's that full length there, understanding the inpatient, the outpatient, labs, scans, and pharma. Pharma, for instance, generic. How much generic pharma do you use? I know there was a recent OECD report in Switzerland that said generic pharma use is quite low in this country. But I understand that's also because it's slightly more expensive as well, so there's a bit of a two-edged sword there. But that's a really big driver in the US as well. Use more generics, drive the cost down. And once you understand the total cost of care, once you've got that picture, you can then start looking at it and analysing it and saying, where can I deliver care more efficiently? Where can I take the bumps out of the curve and bring them somewhere else? Finally, and this is my favourite, sustainability. Value-based care isn't a one-off. We do it once and we say goodbye and we wander down the street. It's about, any engineers in the room, it's the Kaizen approach, the sort of Japanese constant improvement methodology. And we saw in the HVBP example I gave that new measures have been introduced in 2017. New ones will be introduced in 2018, etc. It will evolve. So that's important. And the other one is about, finally, it's sort of aligning incentives. Most providers don't turn up to work to fill in spreadsheets and tick sheets and have interviews about their performance. Most of them turn up to actually make patients better. So I think in terms of winning hearts and minds and keeping value-based programs going forward and evolving, if you can align the way that providers are evaluated and the way they're reimbursed to those care outcomes, to things that really affect the patient and improve the health of us all, then I think that's how you really, really achieve long-term sustainability. I said that was last, it isn't quite. I just want to leave you with this. I'm afraid I've gone back to Toby Cosgrove again, and it's from the same paper I mentioned earlier, but this, I think, is really prophetic. Healthcare is evolving from a proficiency-based art to a data-driven science. It's data, data, data. If you get that right, it's almost Andrew Carnegie, probably the richest man in the world in the early 1900s. Knowledge is power, was his old adage. And I think that's true on value-based healthcare. Thank you.